ZolLifeVest is a proud sponsor of CardioNerds. In a new late-breaking clinical trial, investigators examine the role of the WCD in protecting low EF ischemic and non-ischemic patients during initiation of GDMT. Investigators observed high SCA treatment rates, despite wide use of contemporary GDMT across 19,000 consecutive LifeVest patients. See the latest results at scdprotection.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome, CardioNerds. My name is Rick Ferraro, and I'm an advanced imaging fellow at the University of Michigan and contributor to the CardioNerds. We could not be more excited to bring you this episode on ATTR cardiac amyloidosis, our second in a three-part series, focusing on diagnosis while featuring an incredible teacher, mentor, and clinician who we'll hear from shortly. First, I want to introduce our lead for this series, Dr. Sneha Nandy. Dr. Nandy is currently a cardiology fellow and CardioNerds Fit Fellow and Training Ambassador from the University of Minnesota. Dr. Nandy, great to see you today.
Thank you so much for the introduction, Rick. It is great to be a part of this recording. Today, we are joined by an internationally acclaimed leader in the realm of multimodality imaging. Dr. Venkatesh Murthy is a professor of cardiovascular medicine and radiology at the University of Michigan, where he also holds the Melvin Rubenfire Professorship of Preventive Cardiology. He serves as the Associate Division Chief for Translational Research and is also an Associate Editor for the New England Journal of Medicine Artificial Intelligence section. Dr. Murthy, thank you so much for joining us today.
Thank you very much. It's great to be here.
So today we're focusing on the fascinating but critical topic of diagnosis in ATTR cardiac amyloidosis. Once felt to be a rare entity, the emergence of effective therapies is raising awareness of ATTR cardiac amyloidosis, which can be challenging to spot and diagnose, but early diagnosis is really a key to better outcomes, as we'll get into shortly. For more on the biology of ATTR cardiac amyloidosis, check out our first episode in this series with Dr. Dan Judge.
I'm excited to delve deeper into this topic. So, to bring our discussion to life, let's jump right in with a case from the CardioNerds Heart Failure Clinic. A 75-year-old gentleman named Mr. Mugga presents with progressive shortness of breath, fatigue, and orthopnea over the past 3 months. He has a history of hypertension and bilateral carpal tunnel syndrome. His physical exam is notable for jugular venous distension and bibasilar crackles. His EKG shows low voltage across the precordial leads. Dr. Murthy, what clinical features in this patient should prompt us to consider amyloidosis as a possible etiology?
Thanks. This is a great case and in many ways classic. I think you pointed out that the diagnosis of ATTR amyloid and cardiac amyloid in general can be challenging, although in this case, there are many classical features. Many patients go for years commonly before a diagnosis is made. And now that we have multiple effective treatments, it's important to have prompt diagnosis. So in this patient, Mr. Mugga, who I appreciate the name, by the way, he had a few classical features. So one of them is the fact that he had bilateral carpal tunnel syndrome. That should raise suspicion in any patient that presents with dyspnea or heart failure symptoms. Another classical finding is his electrocardiogram, which shows the low voltage. Overall, these features really do warrant further workup. Commonly, other patients may have features like neuropathy, lumbar spinal stenosis, biceps tendon rupture. They may also present with predominantly heart failure, in some cases arrhythmia. The neuropathy may lead to autonomic dysfunction as well.
Thank you so much for that great overview. It really does help highlight that amyloidosis can present in so many subtle ways that are easy to overlook. Based on clinical suspicion, the team at the clinic went on to order an echo for our patient. It showed moderate concentric left ventricular hypertrophy and diastolic dysfunction. There are quite a few differentials that come to mind when discussing left ventricular hypertrophy. What are some features on his echo that would suggest amyloid over other possibilities?
This is a really good point. Echocardiography really is one of the initial and essential steps in the diagnosis of cardiac amyloid. That being said, the findings of cardiac amyloid on echo can be many, although none of them are 100% required to make the diagnosis. So classically, these include restrictive filling, a relatively small cavity. Large atria are classic, perhaps some of the largest atria you'll find. Thickened valves and speckling can be seen, although speckling is no longer part of the criteria because the settings on echocardiography equipment can cause both false positives and negatives on that. Septal thickness greater than 12 millimeters, and a classic strain pattern, which has been described as vanilla ice cream with a cherry on top, basically apical sparing. Although I should point out that multi-center studies have shown that the sensitivity and specificity of any individual criteria or even combinations of criteria are not very strong. They're at best moderate, and patients can have amyloid with none of these criteria. And there are also some patients that have multiple criteria, but also don't have amyloid. So it's important to go further if you have high clinical suspicion, as in this patient who had heart failure symptoms or dyspnea with bilateral carpal tunnel and a suggestive ECG.
That's incredibly helpful, Dr. Murthy. And it's important, of course, to maintain a broad differential. And we're going to get into a little bit more of the diagnosis here shortly, but it can definitely be a challenging entity to diagnose.
Yeah, I think it's also important to keep in mind that concentric LV hypertrophy, even moderate concentric LV hypertrophy and diastolic dysfunction are common in this age range and are more often than not related to hypertension. That being said, in the high pretest probability patient like this, they should be taken seriously and are suggestive, if not conclusive. It's important to also think about other things that could be causing left ventricular hypertrophy and heart failure. Especially in younger patients, hypertrophic cardiomyopathy may be a relevant differential diagnosis, as well as other infiltrative disorders, storage disorders, for example, can present similarly, but typically in a younger population.
Totally agree on keeping a wide differential and kind of putting all the pieces together as we move through the diagnosis here. And so in Mr. M's case, his echo did show a restrictive filling pattern as well as a maximum wall thickness of 1.7 centimeters at the interventricular site. He was also found to have a small pericardial effusion. The clinic ordered routine labs for further evaluation, such as a CBC and a chem panel. But Dr. Murthy, we were hoping to ask a little more based on your current differential diagnosis, what other lab tests or imaging tests you would order to kind of move the ball down the field here.
Great. I think if I were seeing this patient in clinic, I would be thinking for sure about ATTR cardiac amyloidosis. I'd also be considering AL cardiac amyloidosis. And then as a matter of exclusion, we'd be thinking about hypertensive cardiomyopathy as well as some rarer things. Given that ATTR is at the top of our differential diagnosis, it's important to think about ruling out AL because the treatment is very different and important and can present very similarly. So the way to do this is with a combination of blood and urine studies. The blood studies are to measure serum kappa and lambda free light chains and to calculate the ratio of those and to perform serum and urine immunofixation electrophoresis. And often we will also order troponins and NT-proBNP. These can help further risk stratify patients who present with heart failure type symptoms. But specifically in cardiac amyloidosis, they are part of the staging system that has been put forth by Mayo Clinic and others. In terms of the guideline recommendations for lab testing, however, the critical features are the serum free light chains and serum and urine protein electrophoresis. I've had a lot of thoughts about this over the years, and it's important to keep in mind that these are important to think about, but there may be certain circumstances where their value may be higher or lower. And that comes from, again, thinking about pretest probability. So, for example, if you've had a patient who has a known genetic variant, and we can talk more about that as we come to it, a young patient who presents with neuropathy and heart failure, who has a strong family history or a known genetic mutation, then perhaps the value of AL testing may be lower. The other important feature is how recent do these tests have to be? And many would recommend they be done in the preceding 3 to 6 months or a year. However, again, in many patients, if the pretest probability of AL is lower, perhaps the measurements a little bit older than that might be okay in some circumstances. That being said, I think it's really critical to document that you've thought about it. And there's a strong reason not to perform these tests if you choose not to do that, because you are deviating from the guidelines if you do go down that pathway.
It does seem like it's a critical distinction to make is between AL amyloidosis and ATTR amyloidosis, since both can have overlapping presentations, but they require different management strategies. Our patient, Mr. M, he did have serum-free light chain assays and protein electrophoresis, which was sent, and it returned negative, ruling out AL amyloid. This made ATTR cardiomyopathy a strong possibility. I think confirmation through imaging would be very helpful, but I've always wondered on how to pick between all our available modalities. Dr. Murthy, what imaging tests would you suggest we consider as our next step?
This is a great question. And it comes really from a great place in that cardiologists are blessed with many, many powerful and accurate imaging modalities. In this case, we've already started with an echocardiogram, which I think in general is a good starting point. But as we move through the diagnostic process and have a further increased pretest probability of ATTR, and where we really need to confirm this diagnosis, imaging now is able to do this in a non-invasive way in patients who have negative workup for AL amyloid. There are two basic strategies. One is cardiac magnetic resonance imaging, or CMR, and the other is nuclear imaging with technetium labeled bone imaging agents, typically pyrophosphate and more recently HDP. There are advantages and disadvantages to each approach. So CMR is a great test in patients where continue to have a very broad differential. It can find patterns of enhancement or late gadolinium enhancement, which are suggestive of ischemic heart disease or a variety of non-ischemic etiologies. T1 mapping may be very helpful in finding mimics like Anderson-Fabry disease or others, and HCM may have distinct patterns of late gadolinium enhancement as well as morphologic features from cardiac amyloidosis. Extracellular volume fraction is also very powerful, and if there's a very elevated ECV, that can be quite suggestive of cardiac amyloidosis. However, CMR is not always able to separate out AL and TTR. There are signs that can be suggestive in some cases of the subtype of cardiac amyloidosis, but these are not considered reliable enough to avoid further confirmation, either with biopsy or with nuclear imaging to confirm that the etiology is either ATTR or AL. I should say, though, that CMR is particularly helpful as a follow-up test in many cases if you have a negative nuclear study and a high pretest probability patient. To talk a little bit more about the nuclear side of things, there are really two radiotracers, as I mentioned, PYP and HDP, that can be used reliably. It's important to keep in mind that other bone tracers that are available in the United States are not reliable for detection of cardiac amyloidosis. Unfortunately, the other tracers are more frequently used for bone imaging in patients who may have cancer or other bone disorders, and thus recycling that information, while attractive, is not always reliable. I think the other advantage is that nuclear imaging may be abnormal in early disease. For example, consider patients who are presenting at a younger age, who may have genetic variants and subtle symptoms. In those cases, the amount of deposits of amyloid in the myocardium may be relatively low. And as such, the extracellular volume fraction, or ECV, may still be normal or relatively normal. And the amount of LGE may not be classic for amyloidosis. It's important when looking at nuclear images to perform SPECT in every case, and SPECT CT if at all possible. This helps avoid confusion between blood pool uptake and myocardial uptake. And when you have SPECT or SPECT CT imaging, it's generally straightforward to rate scans as positive or negative based on visual interpretation. But also, we grade the uptake by comparison to the uptake in bone and in ribs in particular. If uptake is similar to the ribs, it's grade 2. And if it's greater than the ribs, it's grade 3. And those patients who are grade 2 or 3, especially with SPECT imaging, are highly likely, with excellent sensitivity and specificity in the high 90% range, to have ATTR cardiac amyloidosis if AL has been ruled out with the appropriate testing we discussed earlier.
Dr. Murthy, that was really a tour de force coverage of the topic, and one that I definitely will want to listen back to because there were just so many pearls there. As a brief follow-up, I'd love to hear a little bit more. This is a little nuance. This is a little level 202 for the audiences. Can you discuss a little bit about the differences between PYP and HTP? Because I think people have heard about shortages and various hospitals switching between one and the other. Do you think you could cover that a little bit?
Absolutely. PYP and HTP are both bone-avid radiotracers labeled with technetium-99m. The imaging technique is relatively similar for both of them, and their performance appears to be similar, although the number of head-to-head studies is quite limited at this point. There are a couple of things to keep in mind. As you mentioned, the supply chain for many of our radiotracers has had some hiccups of late, and PYP is one of those that has had some hiccups. We and others have used HDP with quite good effect. It's important to keep in mind that HDP does clear the blood pool a little bit faster. And so actually that's an advantage in that it enables imaging routinely at about 1 hour after injection. We used to do that also with PYP, but many labs would wait 3 to 4 hours after injection to allow the blood pool to clear a little bit more and make it easier to distinguish myocardial uptake from blood pool uptake. However, with SPECT and SPECT-CT imaging, I think 1 hour works with both, but it works especially well with HDP. There is some concern that if you have very delayed imaging, perhaps at 4 hours or beyond, with HDP, you may have a little bit lower sensitivity due to washout of the radiotracer. But again, the evidence and the details around that are still emerging.
Thank you so much for that. I'm sure our audience has gained a lot of clarity on how to choose an imaging test and how to interpret the information they get from it. After a PYP scan and subsequent genetic testing, our patient, Mr. M, was finally diagnosed with wild type ATTR amyloidosis and started on appropriate therapy. Since we have discussed how varied clinical presentation can be, I think it'll be interesting to discuss another case. A 60-year-old gentleman presents with a 1 year history of progressive heart failure and peripheral neuropathy. His echocardiogram shows left ventricular hypertrophy with signs of restrictive cardiomyopathy. He says that two close family members have been diagnosed with heart failure early in life. Dr. Murthy, would your approach to diagnosis change at all based on this patient's presentation versus our first patient?
Yes, I think it is important to keep in mind that this patient has a history that is suggestive of potentially familial transthyretin amyloidosis. And that's based on the fact that he has peripheral neuropathy, which is less common in wild type cardiac amyloidosis patients, as well as the fact that he's had multiple family members with heart failure early in life. In this case, I often will recommend starting early with genetic testing, in part because some variants of the ATTR gene are associated with false negatives on PYP or HTP testing. And if this individual has one of those variants, it may be more reasonable to start with, for example, a cardiac MRI for imaging after an echocardiogram, which I think has already been done in this case. Importantly, there are a variety of different mutations you see in people from different parts of the world. Worldwide, the mutation from valine to methionine at the 30th position of the ATTR gene is the most common. In African Americans, we often see valine to isoleucine mutation at position 122. And this variant is often associated with cardiac involvement. Other mutations are associated with predominantly neuropathy. Regardless of the mutation, those with familial transthyretin amyloid often present a little bit earlier. This patient is kind of at an intermediate age, which again raises the point of keeping your differential broad. Patients who present in their fourth or fifth decade, particularly men, you should be really worried about genetic variants. But in women or in patients who are older, genetic variants are still possible. When you're talking about patients like our prior case who are in their eighth decade or beyond, the likelihood of genetic variants decreases, but we have still seen cases of genetic variants even in that population.
That's very interesting to know. Thank you so much for explaining to us how our approach should differ if we're suspecting familial amyloidosis versus the wild type, like our first patient. We've definitely covered a lot of ground with imaging and laboratory testing, but I know that sometimes we discuss confirming the diagnosis with a biopsy. Is that something we always need, or is it more of a last resort?
I think in many cases, the clinical picture can be clear based on imaging and laboratory results. So, for example, if a patient has negative serum-free light chains, serum and urine electrophoresis, and a positive PYP or HTP study in the appropriate clinical circumstance, the sensitivity and specificity are sufficient to need no further workup beyond perhaps genetic testing if the patient elects or based on selection of treatment modalities. However, there are many patients which are ambiguous. There may be, for example, a positive serum immunofixation, but a low amount of protein, or there may be imaging that is equivocal or grade 1, for example, meaning less uptake than the ribs, or a patient who has a genetic variant and PYP imaging that's negative, and perhaps CMR imaging that is suggestive or positive. In those cases, it can be very helpful to go on to a further biopsy. Usually, the first step is to do a biopsy of a peripheral fat pad, although sometimes oral mucosal biopsy can also be done. There are a variety of stains that are helpful. The classical med school test is, of course, Congo red, which we've all seen pictures of the birefringence under that stain. Cardiac biopsy is sometimes required, but usually we reserve that these days for cases where there really is a very high pretest probability and a complex set of results that we're seeing. And usually those referrals are made after the patient has been sent to a specialized amyloidosis center. These are the most complicated of cases. And I think for the most part, before a cardiac biopsy is performed, given the high risk of complications with that procedure, an amyloid expert should be consulted to really ensure that what's being done is necessary.
Thank you so much, Dr. Murthy, for those points. It's really a privilege to go through a couple cases with you and hear your expertise on it. One of the documents that I find helpful in the lab at the University of Michigan and just in general is the ASNC Cardiac Amyloidosis Practice Points document, which was released in 2022, as well as the 2021 ASNC AHA ASC Expert Consensus Recommendation for multimodality imaging in cardiac amyloidosis, of which you were one of the authors, Dr. Murthy. And so it's really a privilege to speak with you. I'd love to hear from you, though, kind of following this discussion. What are some of the main takeaways that you'd like our audience to have?
Yeah, if you zoom back out a little bit, I think cardiac amyloid has been a huge victory for patients and for our field in how understanding a disease and hard work from a number of groups that have been really diligent in this space can move the ball forward in both diagnosis and treatment. So when I was in the stage of fellowship, our diagnostics were quite limited. We had a lot of non-specific testing and limited understanding of how nuclear imaging could be used. We had limited treatments as well, and many patients basically saw cardiac amyloidosis as a death sentence. Fortunately, the situation really has changed. We now have multiple effective diagnostic approaches that are predominantly non-invasive, as well as many treatments for both TTR and AL cardiac amyloidosis, which improve quality of life and we believe duration of life as well. So bottom line, I think it's very important to keep this diagnosis in mind when you see patients present with dyspnea and heart failure, and particularly patients who may be older and have LVH, but the differential is broad in these patients. And it's important to have a measured approach to diagnosis and to be careful about resource utilization. That being said, missing either AL or ATTR cardiac amyloidosis in an era where treatments are possible is a tragedy, and we should strive to reduce and avoid that when at all possible. And I think this is a great opportunity, and thank you very much for the opportunity to educate the community about this. I agree that those two documents from ASNC and other societies are a great resource to learn from. I'm very thankful for Dr. Bork and Dr. Dorbala, the leads on the ASNC multi-society guideline, for the opportunity to participate in that. It certainly was a learning exercise for everyone involved, including myself.
Dr. Murthy, we truly appreciate your time and your expertise today. It has been a privilege to learn from you. We'd love to ask you a question we ask all our guests here. And as an expert in the area, what makes your heart flutter about nuclear cardiology?
That's a great question. I mean, I think there's many aspects of it that I enjoy. Rick knows every day I run the nuclear cardiology lab at University of Michigan. and this has been a great privilege. I think nuclear cardiology has a really important role today and in the future in the management of a variety of cardiac conditions. And these are some of the most difficult patients we manage in terms of patients with really complex coronary artery disease, microvascular dysfunction, cardiac amyloidosis, as well as infections or inflammation from cardiac sarcoidosis. These are all really challenging cases. And I think the ability to contribute to the diagnosis and clinical decision making around these patients is super exciting. Our technology continues to advance every single day. The role of AI in this field is just growing by leaps and bounds. So it's alive and well, despite many prognostications in the past that nuclear cardiology's time was over. I think we have a bright future for the field.
That's fantastic. And again, I want to thank you so much, Dr. Murthy, for your time here. It's really been a privilege to learn from you here. And just on a personal note, it's a huge privilege, both your mentorship and your teaching on an almost daily basis in the nuclear lab at the University of Michigan. And extremely grateful for all that you've done for our CardioNerds community here today.
Thank you.
Thank you all. This is episode 2 of 3. And so make sure you check out our 3rd episode upcoming on treatment of cardiac amyloidosis.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Julia Marques. I am an intern in the CardioNerds Academy House Thomas, and I'm a 6th-year medical student at Albert Einstein University in São Paulo, Brazil. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.